This is the Postgraduate Pediatric Orthopedic video series. I'm Mason Alnouri, a Pediatric Orthopedic and Pediatric Spine Surgeon. This is Chapter 18 in the Postgraduate Pediatric Orthopedics book. We're going to be talking about Intrathecal Baclofen Therapy. Chapter 18 in the Postgraduate Pediatric Orthopedics book talks about cerebral palsy in more detail, and there's a separate video about cerebral palsy which you can watch. In the previous video, we talked about this 10-year-old boy known to have cerebral palsy, GM-FCS level 5. He is 17 kgs with severe spasticity, and he had a very good response after the test dose and significant improvement in his spasticity. And so the decision was taken to proceed with intrathecal baclofen pump implantation on a separate day. In order to start, you would need to position the patient in a lateral decubitus position. If he has a lumbar scoliosis, you want to position the patient in such a way where the concavity is towards the table and the convexity is towards you. You would then proceed with standard draping and prepping of the patient, and you would also use an ioban to help maintain a sterile field. You're going to need a image intensifier for the entire procedure, and you want to make sure that you are able to take APN lateral in a standard fashion. And in order to do that, you may want to use a Jackson table, which is radiolucent throughout. However, other surgeons may prefer to use a standard table, and if you are using a standard table, make sure that the table's support is not in the way of your X-ray images. Once you are ready to insert the spinal catheter, you would ask your local representative or your assistant to open up the intrathecal baclofen pump insertion set, which usually comes with its own spinal needle and catheter. The way to insert the spinal needle is slightly different from the standard method which you would usually use during a lumbar puncture and the one that we showed in the last video. The way to insert the spinal needle in this case is through a shallow paramedian oblique trajectory, and this helps the catheter in avoiding any kinks and also allows you to get a good fixation to the deep fascia, which helps to prevent back out and decreases the rate or risk of complications. This technique can also be used for the test dose, especially in patients who have severe scoliosis, because in those patients it may be difficult to use the usual approach between L4 and L5. As you can see, your entry into the skin would be over the L4 pedicle, and you would advance your spinal needle towards the midline. And your needle will enter the intrathecal space between the L2 and L3 vertebra. And you can see here in your fluoroscopic images how the needle starts out around the L4 pedicle area and advances gradually at a 30-degree angle until you have reached your intrathecal space. You want to start with an AP view initially and advance gradually until you see a similar picture to the one in front of you here. Once you're happy with your AP view, go to the lateral view and make sure that your needle is advancing not too shallow and not too deep. If you're going too shallow or you're going too deep, you're going to end up hitting the bone, potentially the spinous process of L2 or L3, and that is okay, because all you would need to do is back out your needle and slightly change the angle. And you can do this under image guidance in the lateral view until your needle is successfully passing towards the intrathecal space. Once it gives way, you're going to do the same thing. Remove your stylet and check for CSF backflow. And if you see the backflow, you know that you have entered the intrathecal space and you are ready to insert your catheter. In preparation to inserting the catheter, you're going to do a standard approach, centraling around the needle entry, but slightly more cranial. And you're going to go down to the fascia and through the fascia, and this would help once the catheter is inserted for your fixation to the deep fascia. For the case presented in this video, we have used the Medtronic Synchromed 2 device, and we had a company representative with us during the case to make sure that someone who is familiar with all the instruments and equipment is around in case. Depending on which device you decide to use for your patient, there may be some differences in the steps for this surgery. You can observe the CSF backflow, the top part of the screen, and this means that you are in the intrathecal space and you are ready to insert your spinal catheter. If the patient only has lower limb spasticity with no upper limb involvement, the tip of your catheter should ideally reach the top of the lumbar spine up to T6. However, if you have upper and lower limb involvement, such as with this patient, ideally the catheter tip should go higher, up to C7 or T1. As you can see, we are bringing in the image intensifier, and the fluoroscopic images will help us to determine where the catheter tip is located. Here you can see after insertion of the catheter, we cannot see the tip here, so we go a bit higher, and now we can see that our tip is around the level of T6, and we go a bit higher because, as we said, the patient has upper and lower limb involvement, and therefore now our tip is reaching somewhere between C7 and T1, which is ideally where we want our tip to be for this case. In case the tip location needs to be adjusted, feel free to push it in further or pull it out, depending on what you see in your fluoroscopic images. Once you have reached this stage in the procedure, if you have another surgeon, he can start preparing the abdominal pocket, as you no longer need to use the image intensifier. As you can see here, he is starting out with injecting some local anesthetic and epinephrine to decrease bleeding at the site. It is important to be meticulous with hemostasis during this surgery for both the abdominal portion and the spinal portion in order to decrease the risk of post-operative wound complications. While the abdominal pocket is being prepared, I am also removing the stylet from inside the spinal catheter, and additionally, I'm also removing the spinal needle. It is important to be cautious while removing the stylet, the spinal needle, and while fixing the spinal catheter to the deep fascia in order not to pull out the spinal catheter or to change inadvertently the location of the catheter tip. The abdominal pocket usually spans 4 finger breadths between the last rib and the top of the iliac crest. The horizontal skin incision should therefore start at the top or superior part of the 4 finger breadths, and this is usually marked before the start of the procedure. In case the patient has scoliosis, especially in the lumbar region, the pump should be placed at the convex side of the curve. In patients who are small and in those who do not have a thick fat layer, extra care must be taken when fashioning the abdominal pocket. Abdominal wall muscles can be quite thin in these patients and easy to damage or penetrate. This would increase the risk of peritonitis and other complications like fistula and infection. When fashioning the abdominal pocket, it should be done from superior to inferior. And you can use a blunt dissection or your fingers in order to make enough room for the baclofen pump. In the top left part of the screen, you can notice the fixation anchor, which is used to fix the spinal catheter to the deep fascia. This is usually passed over the catheter and directly into the wound all the way down to the deep fascia, and you can see that there are 2 holes in this anchor, and you would use non-absorbable sutures to fix the anchor to the deep fascia. Once the spinal catheter is fixed to the deep fascia, there is usually a portion of the catheter that remains outside the surgical wound. This can be cut at a later stage in the procedure depending on the required length for connecting the spinal catheter to the abdominal or pump segment catheter. You can continue to observe the fashioning of the abdominal pocket along with meticulous hemostasis. You can also see the fixation of the anchor to the deep fascia using non-absorbable sutures. After completing the preparation of the abdominal pocket, the baclofen pump can then be inserted into the pocket in order to check for proper fit and tightness of the surrounding tissues and the skin. Once you are happy with the fit of the baclofen pump, you can start preparing the anchoring sutures, which would also be non-absorbable, and they are usually anchored to the 4 corners of the baclofen pump. Some surgeons prefer to only place 2 anchoring sutures, while other surgeons prefer to place all 4 of them at all corners. Should you decide to use only 2 sutures, it is important for these to be at opposite ends, as in the top right and the bottom left, or vice versa with the top left and the bottom right. This is in order to prevent rotation and also to decrease the pressure on the surrounding tissues. Care must be taken when preparing the anchoring sutures, especially if the muscle and the abdominal wall is quite thin, as the suture needle and the sutures can penetrate to deeper tissues. After completion of the abdominal pocket preparation and the spinal catheter fixation, a catheter passing device is then inserted, starting from the spinal side in the spinal wound, and it should be tunneled underneath the skin towards the abdominal pocket, as you can see demonstrated here. A separate pump segment catheter is then inserted into this passer and passed through towards the spinal wound. Once this is delivered at the spinal side, the catheter passer can then be removed. It is important to remember that cutting of any extra length from the pump segment catheter or the spinal catheter can only be done at the site of the spinal wound. The surgeon should therefore be careful and ensure that there is enough length for the pump segment catheter at the abdominal side before cutting it at the spinal side. Usually a 360-degree loop is kept at either end of the catheter, both at the abdominal side and the spinal side, in order to ensure there is enough length for connection to the baclofen pump and also for when the patient grows up. Once you are happy with the length, you can cut any excess length from either the pump segment catheter or the spinal segment catheter. After cutting the excess length from either catheter, both catheters are connected at the spinal side using a company-provided catheter connector. You should then wait and observe for CSF backflow coming from the pump side segment or the abdominal side. And this can sometimes take a few minutes until the CSF backflow reaches the abdominal side. Observing the backflow also ensures that the catheters are properly connected and that the intrathecal baclofen medication will pass through the catheter without any leakage or any problems. The pump segment catheter can then be connected directly to the baclofen pump, and a small gauge needle can be inserted into the catheter access port to ensure that CSF can be aspirated. This confirms that the baclofen pump is directly connected to the intrathecal space via the pump-sided catheter and the spinal catheter. The pump reservoir can then be filled with intrathecal baclofen medication. Preparation of the intrathecal baclofen pump medication is usually done before the case is started. Finally, the baclofen pump can be placed inside the abdominal pocket in the correct orientation, and the anchoring sutures can be passed through the anchoring corners of the baclofen pump and tied down to the abdominal pocket. Some surgeons sprinkle vancomycin powder into the abdominal pocket before inserting the baclofen pump. While there is no evidence to support this practice, we will leave it up to the surgeon's discretion. As you are watching the process of fixing the baclofen pump to the abdominal wall using interrupted sutures, please remember to watch the first part of this video series. And the first part talks about the intrathecal baclofen test dose, where we talk about the indications and some of the methods for deciding which patient should be getting a pump and in which ones is it contraindicated. Moreover, it would be helpful for you to remain updated with the most recent guidelines, such as the NICE guidelines, and also to consult with the product manufacturer and the company representative regarding the suggested indications and contraindications from their side, as these can sometimes change over time. The current indications do not support implanting a baclofen pump in children under 4 years of age. Before starting the closure, ensure copious irrigation with normal saline. The video is sped up in the interest of time. Feel free to watch until the end of the closure. As we are watching, I would like to remind you of some of the post-operative considerations which you need to keep in mind for baclofen pump patients. In the early post-operative period, you should ensure that the wound is checked every few days. Do not expose the wound unnecessarily unless it is soaked or significantly soiled. If so, this could indicate that the patient is developing a seroma, or even worse, a cerebrospinal fluid leak. And in such a case, the initial management involves pressure dressing and observation for potential improvement. If you are concerned that the patient may be developing a superficial wound infection, your wound checks need to be more frequent, and you may wish to start prophylactic antibiotics for the patient. When considering late complications, one of the more common ones we see is the return of spasticity. And this may sometimes indicate a failure of the medication infusion, which could be secondary to a kink in the catheter or secondary to a pump malfunction. Please remember to follow the patient regularly, as some of these complications may not be noticed by the caretaker or parent. Please remember that the patient needs refilling of the pump every 4 to 6 months, and this will depend on the pump size, the reservoir, and the frequency and dosing. Refilling of the pump is a simple and straightforward outpatient procedure that can be done usually with the presence of the pediatric neurologist along with the caretaker or parent, and usually a company representative who is also going to check on the pump and program the new settings for refilling. Once the closure is almost completed, the company representative will provide a way of communicating with the device in order to ensure it is functioning normally and to start priming the medication and to begin the initial dosing and rate as set by the pediatric neurologist who is following the patient. The neurologist can also monitor the patient in the post-operative period in order to check for spasticity improvement and overall response to the set dosing and frequency. And this can then be increased or decreased depending on the response as guided by the neurologist. The wounds can be closed in layers using absorbable sutures. Some surgeons prefer to close it using a mattress suture. It is the surgeon's preference that determines the closure, but make sure it is watertight. After completion of closure, a standard dressing can be used initially and then reinforced by a pressure dressing like Curafix in order to decrease the rate of seroma and other wound complications. This will take us to the end of this video. I hope you find it useful for your examination or clinical practice.